What I'd like to do in the next little while is compare and contrast the two dominant forms of ablation that we use now for atrial fibrillation, namely radiofrequency catheter ablation and the cryoballoon ablation strategy. To start with, we have to, of course, pay homage to where this whole field started, as Stuart said, 20 years ago, over 20 years ago, with the discovery of the critical role of pulmonary veins in triggering paroxysmal atrial fibrillation, and the fact that they could be ablated, the foci that cause AF, to potentially provide a cure for this condition. The first probably 5 to 7 years of AF ablation were dominated by conversations between two large groups, one being Michel Hassaguer's group in Bordeaux and the other being the Milan group of Carlo Papponi. And at many meetings there was quite heated discussion between the two groups as to how AF should be ablated. Hassaguer said that you should be aiming to do the ablation osteally, to ablate those connecting sleeves that join the pulmonary veins to the left atrium, and you should prove that they're disconnected by putting the lasso catheter that they developed, this circular catheter in there, to prove that you've isolated them. Papponi used one of the electroanatomical mapping systems that Stuart just described and did wide area circumferential ablation, or what's known as WACA. And he wouldn't actually establish whether there was isolation of the veins or not. His endpoint was looking at how much you could reduce the size of the signal as you did that ablation. And the two would argue, and other groups weighed in on the conversation, till eventually a consensus was arrived at towards the end of the 2000s that the two approaches really merged, so that the best approach was considered to stay outside the vein for safety reasons, to avoid pulmonary vein stenosis, but also that not only should you do it widely, do the WACA, but you should check that you've isolated the veins with the lasso catheter. From there, as Stuart said, there was the merging of CT scanning with the mapping systems to generate a geometry. And then we moved on to a system of lesion location, so we knew where our catheters were, where they'd been, but also an assessment of how adequate our lesions were by integrating contact force into the equation. So catheters that could record how much tissue contact we had. Because for a number of years we would be relying on seeing a large electrical signal and thinking we had good contact with the tissue and delivering a lesion, whereas studies in the animal lab showed us that quite often, despite having good signals, we weren't actually making much tissue contact and therefore weren't generating lesions. And the final iteration of that process was to incorporate power into the equation. So we'd look at contact force, stability, time and power into a weighted algorithm that would tell us how effective our lesions were. And with the final iteration, which is this ablation index used by one company, but one of the other companies has a similar algorithm that tries to tell you how effective your lesions are, the single procedure success rates in the last few years have improved significantly. And this is the contact force sensing catheter. It's got a system in it to record and give you real-time data on how much contact force you're applying. And these lesions, these dots, represent whether you've achieved the target of what's called the ablation index, which relies on power, contact force and time. And so once we've achieved our target, then we move on and deliver the next lesion. And this shows a CT scan. And where we are now is this is the left upper pulmonary vein, this is the left lower pulmonary vein, this is the left atrial appendage, and we're delivering lesions down the ridge that separates the left-sided pulmonary veins from the left atrial appendage. And we've got our contact force being displayed here in grams, so this is 17 grams. And we try and get at least 10 and ideally up to 20 grams of force. And with that system, in this recent publication, using the latest iteration of the algorithm called Ablation Index, this study demonstrated at 12 months 80% freedom from symptomatic atrial fibrillation. So our current workflow at North Shore Hospital, North Shore Private, where I work, is that we use CT scan, we integrate that into our mapping system. We do a toe on the day of the procedure, single transeptal puncture to access the left atrium, pass our second catheter through the same puncture hole. It's done under GA because it's uncomfortable, and if the patient moves around, that messes up your map, and it enables us also to put an esophageal temperature probe down to check on the esophagus and try and avoid excessive esophageal heating. We do a wide area circumferential ablation using the ablation index system, and we confirm isolation with the lasso catheter, and we do a voltage map, as Stuart just showed, to confirm that. And if we need to do a flutter ablation, we'll add that on. And overall, in the last 150 cases that we've looked at, the procedure time is around 100 to 120 minutes. Now this is a voltage map at the end, just demonstrating that the veins are isolated and you have healthy, normal voltage tissue between those two rings on the posterior wall of the left atrium. But radiofrequency pulmonary vein isolation is technically challenging. There is a fairly long learning curve to it, and there's been concern about the durability of lesions, lesion in contiguity, and trying to avoid collateral damage to other structures such as the phrenic nerve and the esophagus. And there's also been the issue of time efficiency, trying to do the job as efficiently, effectively as possible and not spend excessive time in the left atrium. And this has led to the development of the sort of single-shot balloon technologies, of which cryoablation is now the most widely practiced. The cryoballoon ablation system involves an over-the-wire system. It's a balloon where pressurized refrigerant is passed down the catheter to the tip. There's a phase change, there's a reduction in temperature to a maximum of minus 80 degrees, although that is certainly not the temperature targeted in balloon ablation of the pulmonary veins. And the heat is absorbed from the surrounding tissue, and then the refrigerant is sucked back by a vacuum back to the console. And this diagram here just shows a balloon in the ostium of the pulmonary vein. Contrast is injected to make sure the seal is adequate, and this is the recording catheter to record the electrograms. At the end of the isolation period, then the electrograms are, the circular catheter is put in there to determine whether there's isolation. And there have been two iterations of cryoballoons, which the first was developed in 2010, the first generation, and the second generation in 2012. And the second generation balloon was delivered a more distal and more uniform freezing of the vein. The first iteration tended to produce more an equatorial sort of freeze, and this one was found to be more effective. So a cryoballoon workflow, many places will do the procedures under general anaesthetic because the phenomenon of ice headache, when the balloon's inflated and freezing's occurring, patients often get this headache, which is like what you get if you get an ice cream headache or too cold a milkshake, and it's quite uncomfortable. And so a lot of centres do prefer to do them under general anaesthetic, and also because whilst the balloon is being inflated and freezing is occurring in the right-sided veins, particularly the right superior vein, pacing of the phrenic nerve is undertaken to monitor for phrenic nerve injury, which is a more common side effect with this type of ablation than with radiofrequency ablation. And it's uncomfortable to have your phrenic nerve paced continuously. Single transeptal puncture, the balloon's engaged, occlusion checked, and then these days 2 3-minute thaws, freeze-thaw, freeze cycles to achieve ablation. As I said, the phrenic nerve is paced and the diaphragm is monitored either with a combination of manually feeling the diaphragm to see that it's still twitching each time the phrenic nerve stimulated, or some centres use a monophasic action potential monitoring of diaphragmatic potentials. And then PVI is checked with a circular catheter. And any touch-up ablation can be done usually with a radiofrequency catheter. And these procedures now, from the literature, generally in experienced hands, taking again about 90 to 120 minutes to perform. This was a recent study looking at 3-year results from cryoablation, showing that at 12 months there's about 79–80% freedom from atrial tachyarrhythmias, which is up down to 65% at about 3 years. But still fairly good results and comparable to radiofrequency catheter ablation. So how do we choose between these two technologies? They both seem to be efficient and effective. Well, let's look at safety first of all. These are the sort of list of a variety of complications that can occur with radiofrequency and cryoablation, and the number of plus signs here really just as a general idea to indicate that really vascular complications should be fairly similar between the two approaches. Stroke and TIA should be similar because you're accessing the left atrium. You still have to be anticoagulated with either form of therapy, and there don't seem to be significant differences in stroke. Some studies have suggested a slightly higher chance of pulmonary vein stenosis with particularly the early cryoballoons, but with the second generation, that complication seems to have been reduced markedly, and with the WACA approach with RF ablation, we really shouldn't be seeing pulmonary vein stenosis. Pericardial tamponade has been reported to have been slightly higher in RF ablation, possibly before the advent of contact force catheters, when we wouldn't know exactly how much force our catheter was generating as we moved it around the atrium. And I suspect, although it's yet to be proven, that the incidence of pericardial effusion and tamponade has gone down with a more careful monitoring of contact force. Irritation of the gastric nerve plexus and gastroparesis can occur with either modality. Esophageal perforation and fistula is the most feared complication of ablation, and now seems to be, we think, much lower than it was in the early days of ablation, with more attention paid to esophageal temperature monitoring. Overall, reported to be higher with radiofrequency than cryoballoon ablation, although it has been reported with the cryoballoon, but we should be talking in the range of 1 in 3,000 to 1 in 4,000, and so it's a very small numerator and a large denominator. Phrenic nerve palsy is undoubtedly more common with the cryoballoon approach, as is the small incidence of lung or bronchial injury from the cryoballoon. But complication rates with both forms of ablation have reduced with time. In terms of efficacy, there have been meta-analyses looking at the comparative efficacy of radiofrequency and cryoballoon. The problem is that this is the age-old issue of apples versus oranges when you're trying to look at meta-analyses that have covered periods of time where there have been significant changes in technology through that period. You're not always going to be comparing the newest and the best technology. The two most robust studies that we have comparing contact force, which is the latest form of radiofrequency ablation, with the second generation cryoballoon, with a fire and ice study, which has been published in complete form, and the circa dose study, which has only been presented at the EHRA meeting this year, and we only have limited information from that study. From the meta-analyses, and this one, I could have chosen one of about 6 different meta-analyses, all have published in the last 2 years or so, but this one from Murray, looking at efficacy of the two approaches at 12 months, no significant difference between cryo and cryoballoon and RF. Safety complications overall are similar, although as I've just mentioned before, there are different types of complications that are more likely to occur with one form of therapy than another. Rates of reablation, no statistically significant difference between RF or cryoballoon. So the sort of meta-analyses, as murky and as difficult as they are to really assimilate, suggest that there's a fairly similar freedom from AF at 12 to 18 months with both approaches, with similar recurrence and redo rates. But there does seem to be a slightly shorter procedure time with the cryoballoon, which is one of the reasons it's become attractive and is increasing in its popularity. There's a longer fluoroscopy time with cryoablation because you do need to inject dye and contrast to see that you've got adequate seal, and an increased radiation exposure, whereas with the RF ablation we try and rely as much as possible on the electroanatomical map to move around rather than shooting X-rays the whole time. And a similar complication rate overall, but with more phrenic nerve injury risk with the cryoballoon, and possibly more perforation tamponade risk with RF, although, as I said, that may be changing and may have changed with the contact force catheters. So this is the fire and ice trial. This was a trial, Karl-Heinz Cook was the lead investigator on this. Over 700 patients, a randomised controlled trial, which had at its endpoint to look at the question of whether cryoballoon ablation was non-inferior to the gold standard at that stage, which was radiofrequency ablation. It contained a mixture of cryoballoons, both the first and second generation, and also a mixture of irrigated ablation catheters, the Thermocool SF, the Smart Touch Thermocool. But of note, contact force catheters were only used in 24% of the patients in this trial, and that's the latest generation of RF versus the second generation balloon for the cryo side, where 76%. So again, we've got this problem that you've got half the treatment group receiving predominantly the latest technology, whilst only a quarter of the RF group were using what we would consider now as our best RF ablation technology. So the results showed that the event rate at 12 months, which included recurrence of atrial arrhythmias, need to go onto drugs, was similar in both groups. The rate of reablation was higher in the RF group than the cryoablation group. The rate of rehospitalisation was also increased in the RF group, and the procedure time was about 20-25 minutes shorter in the cryoablation group. As expected, the rate of phrenic nerve injury was higher in the cryoablation group. So this study began in 2012, which was before the advent of contact force catheters. But interestingly, a lot has been made about the reablation rate being lower in the cryoablation group, but a subsequent publication from Karl-Heinz Cook in Journal of the American Heart Association actually looked at comparing the group who used contact force catheters in that study compared with those with the second generation cryoballoon, and there was in fact no difference in the rate of reablation, coming back to that point of comparing the current best apple with the best apple. And this is the latest study, the Circa Dose trial presented at EHRA, and this looked at two forms of cryoballoon, using cryoballoon inflations for 2 minutes, two 2-minute cycles as opposed to the conventional 4-minute cycles, comparing that with contact force radiofrequency ablation. And it included 8 centres in Canada, over 350 patients, and the strengths of this study was that it was the most tightly adjudicated study for recurrences. All the patients had loop recorders, so we know we're not just relying on symptoms. They were all using the current generation of cryoballoon and contact force catheters. They were a mixture of paroxysmal and persistent AF patients, and the arrhythmia burden was very clearly documented with the ILR. And so you could actually discriminate absolute freedom from atrial arrhythmias from simply symptomatic freedom. They didn't use the ablation index, but I think this is a really good study in terms of trying to give us an answer as to the comparison of the two latest technologies. And what it demonstrated is that the single procedure freedom from any atrial tachyarrhythmia, as adjudicated by the loop recorder, was really no different between the shorter cryoballoon applications, the conventional cryoballoon application, or the contact force RF application. And the single procedure freedom from symptomatic AF was greater, typically around 73% for the cryoballoon and 79% for the contact force RF. Again, no statistically significant difference. So the interest will be when the full paper is released to teased down, but it really tells us that we know we are missing patients who are having recurrent AF, but the question is it clinically significant RF? Because to get be documented as a recurrence in this trial, all you had to have was 30 seconds of AF picked up on an ILR, and most of us, I think, would admit that that's probably not terribly clinically significant if they have 45 seconds of AF in 6 months. The patient's still very happy, but strictly by definition, they've had a recurrence. So to finish up, what are the potential advantages of the cryoballoon? Well, it's a simpler technology, it's a shorter learning curve, it's probably more reproducible, particularly in low volume centres or less experienced operators. It does seem to have a reduced risk of fistula, although that is now becoming a much rarer problem. Shorter procedure time, you could argue with. Many centres now with RF are achieving the same sort of procedure time of around 110 to 120 minutes as cryoballoon, and it has a similar efficacy to contact force ablation. The disadvantages of cryo is that there is a higher risk of phrenic nerve injury and of bronchial or lung injury. It's not suitable for complex linear lesions such as we need with atrial flutters, which can be needed in up to 30% of patients. And touch-up ablation, if it is needed, is usually done with RF. It does have higher fluoroscopy and radiation exposure, and it's not really suitable for the more difficult, challenging anatomy like large, long, common antral. The potential advantages of RF ablation is that we have a wealth of experience with its use. We can tailor it to all anatomies. We can do linear lesions, complex lesions, flutters. It does have a lower risk of phrenic nerve injury and a lower risk of bronchial injury and less fluoroscopy. And it does allow us to ablate more extensive substrates, flutters, and particularly do posterior left atrial isolation in patients with persistent AF. But the disadvantage is that it does take longer to achieve technical expertise in this modality. It's challenging. It may be less reproducible in low volume centres, and it may be a slightly longer procedure, but probably only by sort of 10 to 20 minutes. There is a slightly higher risk of esophageal fistula, but the overall risk in a recent survey of about 400 centres incorporating over 190 ablation procedures was quantitated at about 1 in 6,000. It's probably higher than that because this is a self-reported series, but it's still very low. And although the Fire and Ice trial suggested a higher redo rate, as I've presented there in a subsequent paper, if you're using the current contact force ablation, it doesn't seem to be any higher redo rate than the cryo. So I think in 2019, the choice really depends on the operator experience and volume. The results with both balloon and contact force are fairly similar. The overall complication rates are similar with the other caveats of specific complications. The cryoballoon may be the preferred one for people starting out or in lower volume centres, or people who just find it more comfortable and less stressful modality. And a lot of my colleagues who do cryoballoon say they just feel more relaxed doing that, they're used to it. More complex substrates, RF would be the favoured modality. But anyone who's a cryoballoonist, so this is the junior or younger colleagues learning overseas, have to still be competent in how to move an ablation catheter, an RF catheter around the left atrium, because they're going to need to do flutters and other more complex things. So even for the devotees of RF ablation, balloons may, however, be coming into the fore with a variety of new balloon technologies being developed, and this is the latest one from Biosense, which is actually an irrigated RF balloon, which is in its early phases, and even if it doesn't work out to be effective, would prove to be a very popular bath toy for my grandson, because you see. So that's all I'd like to say at this stage on the comparison of the two, and happy to take some questions later. Thank you.